On behalf of the InCK Marks Initiative, we are recording. You just got a warning of that. We have a packed agenda. I'm very honored to have been with Maxine Hayes, the co-chair for the InCK Marks National Advisory Team, and really am delighted to see the summary that you're going to hear about today. We're going to hear from Charlie Bruner. We're going to hear about the 6 years of work that was funded by the Robert Wood Johnson Foundation. And we're going to hear from some very special speakers and commentators during this webinar. So Charlie, I turn it over to you.
Well, thank you, Kay. And first, I want to thank everyone participating in this webinar. Most of what I say as conclusions from InCK Marks' work will not be new to you. In fact, much of it is the result of our learning from your on-the-ground work and your research and policy development and implementation action. Second, I want to emphasize that I'm not taking the words truths and imperatives lightly. I use them because now is not the time to be tentative in asking for what we know is needed. 4 years ago, Martha Davis asked me, after I had completed a health equity in young children initiative supported by the Robert Wood Johnson Foundation, if I would be interested in a small grant to continue that work with a focus upon integrated care for children. For me, the funding was remarkably generous, enabling me to connect with others in the field and draw on their work and thinking without an organization to maintain. While forcing me out of retirement, it strengthened my optimism, resolve, and resilience.
Charlie, you need to unmute yourself. Sorry.
Did you hear anything?
Now, yeah, just keep going. We only had a brief interruption.
Okay. Well, not necessarily planned that way. Our work aligned with Robert Wood Johnson Foundation's overall work and evolution in the field, with the distinction that our focus was specifically on child health. RWJF's Building a Culture of Health emphasized the need to broaden health's attention to more than the treatment of disease and disability. Its aligning systems work emphasized the need for viewing health roles across healthcare, public health, and human services. Its focus upon racial equity emphasized health's responsibility to rectify inequities and contribute to undoing racism. And although not in that same order, InCK Marks' evolution really emphasized these same foci, but with a specific reference to children. Trying to move the presentation to the next slide. So
try clicking on it and then moving.
Our 5 years primarily focused upon summarizing, synthesizing, and assessing the state of the child health field in responding to social as well as medical determinants of health, and optimizing child health across physical, cognitive, social, relational, and emotional behavioral dimensions of health. We didn't do original research, but found that there was a growing body of work and evidence supporting child healthcare transformation, even though most of the attention in healthcare was focused elsewhere on high-cost, chronic, and end-of-life healthcare. This slide shows that we produced a lot of stuff with a lot of colleagues and leaders, and with a framework that really, I think, embodied what the field is working on. Probably before the end of these 5 years, but definitely then, Martha Davis encouraged and strongly nudged us to synthesize our key findings and messages for the field in clear and actionable ways. This presentation is an effort to do that around 3 summative conclusions. I will go into each in brief detail. Our synthesis of work in the field and other InCK Marks stuff provide many of the devil in the details enumerations of them. Here are our 2 core truths and consequent imperative. I hope these are not new to you. I later will go on each in a little detail to present as quickly as possible the evidence and truth behind them. First, to achieve racial equity in health requires a focus on children, which is a very significant departure from where the major attention on healthcare is today, which is on adults and those with high-cost conditions. Second, this requires an approach to healthcare that is more preventive, promotive, relational, and ecological. And we have tremendous evidence and practitioner champions in the field which are doing so with great results. Third, public sector investments are needed to truly advance this work, which requires the recognizing the value of doing so. This requires a different and really an investment approach to value-based care that is different than that taken with adult chronic populations. So I'm going to provide a little bit more detail on each of these. And in terms of the focus on children, we all know that there are profound disparities in health outcomes by race and ethnicity in the US. We have a wealth of statistics across medical health, safety, and cognitive, social, educational, and emotional development in health that show such inequities. Whether the result of current personal and institutional racism or historical disadvantage and inequity, these are unhealthy for our society. But we know the opportunity to rectify such inequities are greatest with children. The next slide provides 4 different reasons we must prioritize children in addressing racial health inequities. And first, the first 2 bars on this slide provide a numeric reason. Children are the most diverse age group in our society, and we have the greatest overall concentration of people of color among children. Half of all kids are of color compared with a quarter of the senior population. So that alone says we've got to focus attention on children. The next 2 bars speak to our role in providing public health through public systems, where society has taken that responsibility for seniors under Medicare and low-income populations under Medicaid. While only 1/4 of Medicare recipients are of color, nearly 2/3 of children on Medicare are. In our approaches to supporting publicly financed healthcare to rectify health inequities, we must look at children and Medicaid. The final 2, the next 2 bars speak to responses at the community and public health level, which will be the next slide subject. It is particularly incumbent to focus upon children in our most underserved and poorest neighborhoods. And the final 2 bars speak to the duration and impact of actions. Think life course impacts in the Heckman equation. Gains made in health for children impact health over nearly 7 decades. Those for seniors at best are barely 1. Further, our ability to impact trajectories are greatest in these critical development years in childhood. It should therefore be a no-brainer that when thinking of the health system's role in advancing racial equity, the focus be on children. I do want to elaborate a little on the 3rd set of bars using the CDC's own social vulnerability index, which CDC developed to identify poor and underserved communities requiring special or increased healthcare responses. This slide compares the 10% of census tracts with the highest vulnerability, where 31 million people live, compared with the country as a whole. The first set of numbers shows that poverty level, educational level, single parenting rate, and unemployment rate in these tracts are double that for the country as a whole, creating challenges for raising children and the need for community building as well as individual service strategies. Less well recognized, the figures in red show that these tracts are rich in children and racially quite segregated and often marginalized as a whole. Responses in these tracts require much more focus upon children and families and less on seniors. Moreover, 4 in 10 children of color reside in these tracts, and they are by and large the most vulnerable of all children of color in society. Public and community health responses are most needed here and are most needed with respect to children and their opportunities. Well, the preceding slide showed the need to focus attention on children, but did not describe what to do in focusing that attention. The fact is, we know a lot. First, we have the parent science for multiple disciplines that all points to the primary role that family and home environment play in child health and development. All emphasize the critical importance of the safety, stability, and nurturing in the home environment to optimal child health and development. Second, we have a large body of research through both primary child health care and community health of strengthening the safety, stability, and nurturing in that home environment. While it has not necessarily been neatly arranged, it is compelling as the next slide presents. We have evidence-based programs in particular that have added what a community health worker, a relational care coordinator, a home visitor, other staff who builds a relationship and works with families to support them in nurturing their children. These come by many names, but we know the qualities of such workers, engendering trust and accompanying family that produce impacts. They have demonstrated their impact and value, and there is a tremendous amount of research evidence to say so. We also have well-developed programs and practices within primary child health that do so, including Healthy Steps, which Rahil Briggs, one of our initial responders, leads. And we have numerous indigenous efforts within health systems, particularly federally qualified health centers, that have shown themselves to do so. And we have examples in many of our publications. Importantly, these share common underlying attributes, consistent with the principles of a medical home. They are exemplary evidence-based practices, but moving them from efficacy to effectiveness requires attention to these attributes. Fortunately, we have practitioner champions and leaders who can do so. So in short, these have extremely high value, although we are not reflecting this in our public financing today. Before I go to the imperative, I want to emphasize that we really have more than enough knowledge and evidence to act upon at the federal, state, community, and neighborhood levels. I love continuing to raise new questions and finding out how to do things better and getting into the nuances of what works best, where, when, and how, but we don't need more research and data to use what we already know to take bold action. So this leads me to using these first two truths to take action. While there are others, I think two action imperatives stand out, and we are ready to act upon them. One involves investing in primary child health care, particularly through Medicaid, and one involves investing in public and community health, particularly through a community health workforce. Our current investments in both fall far short of realizing the value of such actions. Both require enriched investments commensurate with their value. Regarding primary health care, the composite of exemplary programs and practices, as well as the guidelines for bright futures and the principles of a medical home, call for doing more and different in primary care. Current practice is financed to at best identify and address medical conditions. Responding to the overall health of the child in the context of the family requires more time and attention to the child and family and their overall health needs. Kay and I have described this as a high-performing medical home, and it reflects such practice and research in the field. It needs to be financed, particularly through Medicaid, at a much higher rate than the current standard of care, to enable practices to be able to actually do it. The same holds for public and community health and responses. A recent international publication of monographs concluded that the evidence for community health workers to improve population health is incontrovertible and an essential component to a health system. It also emphasizes its effectiveness is dependent upon proper design and implementation, e.g. fidelity to the attributes I discussed. A number of very recent publications in the United States, including one authored by our other initial responder, Mayra Alvarez at the Children's partnership attest to the value and potential of such investments. As with primary healthcare, community healthcare workers need to be publicly financed, particularly in low income and medically underserved communities, in much higher numbers and with more support and recognition for the value they provide. My final two substantive slides speak to the opportunity available to us to do so. We have the knowledge, know-how, and commitment to advancing this work, and we need to build upon the readiness at the federal level to do so. First, the federal administration has made commitment to racial equity and racial equity in the health system in particular. We can provide the devil in the details on doing so, but we also must exhort, nudge, and applaud administrative actions in these directions. We have to remind them that kids matter and health plays a critical role in achieving racial equity. President Biden, CDC Director Walensky, and CMS Administrator Briggs and their staff need our briefing and voice to go on to do what they're committed to do. And I do want to have a shout out to all the folks at HRSA and MCHB who have been doing this for decades, literally decades, in the last 2 decades with ECCS. Second, we need to build upon congressional leadership and the president to building back better and with respect to public and community health in expanding and strengthening the community health workforce. They are talking about truly transformative investments. Whether administrative and congressional leaders necessarily put all the pieces around the particular role of child health to this end, they are positioned to do so. Senators Murray, Casey, Gillibrand, and Warren, and Representatives Khanna and Panetta can be a nexus for action in Congress, and they and other members of Congress need to hear from us. I'm now going to close my mouth and listen and only say a few words at the end about next steps. I really do think that these 13 words here are as succinct as I have ever been on linking research and policy. I will now turn it over to Rahil, Briggs, and Mayra Alvarez for kickoff commentaries, with Kay taking over in facilitating the further dialogue.
Thank you so much, Charlie. While I'm introducing you, Rahil and Mayra, I know we all have really short time to talk, but Dr. Rahil Briggs is the National Director of Healthy Steps at 0 to 3, and she brings a wealth of knowledge from her experience as a clinical leader, from a teacher in academic settings, and all of that knowledge to ground her work in leading a national movement in growing healthy steps. Mayra Alvarez is the president of the Children's Partnership in California, taking over from some groundbreaking advocates that many of you know led that initiative early on, and the way that the directions that Mayra has led the Children's Partnership have influenced advocacy all across the country, and we were pleased to have her a part of the National Advisory Team for InCK Marks. She previously served in the Obama administration and roles in HHS, including at CMS. So Rahil, I turn it to you.
Thank you, Kay. Thank you, Charlie. I'm just going to make some quick remarks on what Charlie shared with us all, because I'm really eager to engage in conversation with everybody. And just to underscore a couple of very important points. This pandemic has made it impossible to ignore health equity and the challenges we face. And these challenges start with babies. That is where they start, and we might as well solve problems where they start. We know from the State of Babies yearbook that 0 to 3 puts out every year that while 1 in 5 babies are born to families living in poverty, and that's about enough, 1 in 5 should shock us. Those numbers are doubled and tripled respectively for Hispanic and Black babies. We know, as Charlie said, all the science. We know that early adversities literally get under the skin. They change brains, they change bodies, and potentially for a lifetime. And therefore, if it's predictable, it's preventable. We have to reach babies during this really critical period of brain development. And the pediatric healthcare system is the single system we've got in this country with the capacity to do so. Our early childhood system is pretty siloed otherwise. We've got home visiting over here, pre-K over there, and nothing is scaled anywhere near pediatrics, and I include family medicine and pediatrics. It's anyone providing that well child care to children. Pediatric visits as we have them now, as they're structured and paid for, are not enough, but this system must really be at the center of any approach that we have to influence collective prosperity and flourishing. And so for this system to meet its promise, we've got to advocate and pay for team-based care, not just doctors shouldering the entire responsibility. A really quick example of team-based care closing equity gaps in Anacostia in Washington, D.C., the most disadvantaged neighborhood in our capital. Healthy Steps at Children's National reaches over 4,500 families annually, the vast majority of whom identify as Black. And the Healthy Steps team there reflects the racial and ethnic backgrounds of those patients. They're building trusted relationships. They're ensuring universal screening, in-house intervention, and effective follow-up to community services when needed. And this team in this community quadrupled the likelihood of successful early intervention referrals. We already know how important it is to treat things early. It's about getting families there and erasing those equity gaps. Just a really quick note, while almost all of their patients identify as Black, our health system across this country really struggles to get good data on race and ethnicity. And it's a big lift for providers at the local level to gather race and ethnicity data that's reliable, that's standardized in a meaningful way. And of course, what they do collect is then filtered up to MCOs and states. We need a common set of definitions and terms to capture these data. Without it, we're going to continue to struggle to demonstrate large-scale impact on equity, not necessarily because the work isn't being done, but because we don't have the data to clarify that impact. And finally, we have to pay for prevention, as California is starting to do. I'm so excited to hear from Mayra. Our healthcare system in this country is among the best in class when it comes to solving hard problems. We can treat difficult diagnoses, we can innovate on solutions for those problems, but we're down in the bottom when it comes to prevention. And I just want to encourage us all to imagine a future if every family with young children had access to team-based primary pediatric healthcare, whether it be Healthy Steps or under other wonderful models like Dulce and VIP. Our ongoing costs at Healthy Steps are as low as $5 per family per month, and show an average return on investment of over 150% in a one-year time frame. So let's do this. Let's emerge from this crisis refocused on the best investment I think we can ever make as a society, and that's on our youngest children. Thank you.
Thank you, Rahil. Mayra?
Thank you, Kay, and thanks for the opportunity to respond and to follow Rahil's comments. My remarks will be very much in line. I want to start with what Charlie really opened up with and called on us to really challenge our system to focus more on children and more specifically to focus on relationships. And when I talk about what we need to do now to capture this moment, to not go back to business as usual, I often refer to 3 Ds of disrupt, defer, and demand. And they actually align very well with what Charlie has said. First around disrupting, just really disrupting our oppressive systems and old ways of thinking in order to better serve kids and families. We have seen decades of research that outline the inequities in health status that have made clear what racial disparities exist. And right now we need to step back and really question what are the underlying assumptions that shape our systems that are perpetuating these inequities and the policies that they implement, and really seek to abolish racism from every institution, every policy, every social norm in which it operates. But not only operates, it often hides. And we see what these policies are doing to many of our families and why we need to think different, why we need to disrupt these systems. And part of that is really addressing the broader capacity and culture of our healthcare institutions of us as individuals. So not only collaborating with community partners and those outside of healthcare, as Rahil mentioned, but also the cultural humility of people delivering care, anti-racism training for our administrators, for our staff, and our own governance structures. And part of that is supporting a community health worker workforce that moves us further because it shifts power through partnerships in which people who directly experience the conditions that cause inequities have leadership roles and opportunities to share their perspectives and influence healthcare delivery. And that's only possible through fundamental changes in payment and performance measurement. The second is around deferring to the knowledge, expertise, and power of our communities. We know that it is out of necessity that many communities created these networks of care. They trained community health workers. They integrated care into community settings because the traditional healthcare system was not meeting their needs, or worse, was mistreating them. So advancing health equity really requires us to build on these efforts and identify ways to meaningfully incorporate community voice in care delivery, from ideation to execution. And that's everything from community advisory groups that we know exist, listening sessions, community leadership, but really finding ways to value community voice, community leadership, and ensure that our system is then responding to the needs of communities more effectively. And then my final message is for us to demand different, demand better for our children, for our communities, for our entire country. Right now, our healthcare system, we're not able to address every challenge in society that impacts the well-being of our kids, but it can evolve itself to work in greater collaboration with other partners to take this whole child, whole family approach in care delivery and really move upstream to address social determinants of health, housing, transportation, immigration, and food access. Many of the components that these integrated care delivery models, like Healthy Steps, like a Dulce, take into consideration in order to be most responsive to families. So finding ways to strengthen these investments in community-based collaboratives, to assess and prioritize attention to what the community says it needs, to run by community-based entities and partner with health plans. That is what we need to do in order to be more responsive to our kids. And I will close by also emphasizing what we know to be true is that when we follow community, we follow the strengths of what we know communities have, this real strength-based approach to advancing health equity, emphasizing the protective factors of race, of ethnicity, of culture, and valuing culture as a health intervention in and of itself for our kids, for their families, and for our communities as a whole. With that, I'll turn it right back over to Kay.
Thank you so much, Mayra. And I just want to credit Mayra and Rahil for saying so much in the 4 minutes we gave each of them to tell us their lofty thoughts, and so much was shared in those ideas. So we're going to engage several people in dialogue, and I kind of have a starter list here about the ways that we can focus on children, build on what works, and invest in value. And I'm going to call first on David Willis. Each of you has the ability to unmute yourself.
Thanks, Kay, and it's great to be with everyone. And Charlie, thank you for your leadership, especially around the critical elements of course, investing in primary care, as Rahil alluded to, and in partnering deep with families in those, as you called out, relational health workforce development. It's an honor to follow Rahil's comments about the criticalness of the child health sector. And Rahil's, it all starts with babies, and I would say it starts with safe, stable, and nurturing relationships around babies too, which requires that we likewise, as Mayra called out, be deep within partnering with communities to their strengths, to their relationships, to their networks, and their support efforts at the same time. That calls out the AAP policy statement in August that said preventing childhood toxic stress means partnering with families and communities to promote relational health. We're moving into the criticalness at every sector of partnering strongly to the relational health of families, to the benefit of that next generation of our young children. And now in face of COVID, there's never been a more critical element to rally all of our forces for the next generation in the support of fathers, mothers, and babies together as each new baby is born. So it's a critically important time for thinking about investments. I just heard last hour that come May, the second half of the dollars from the ARPA go to counties. How do we make our voice loud and clear as to the opportunity of bringing the community into the medical home in terms of the opportunities for the next generation of children? Those are my comments, Kay. Back to you.
Thanks so much. So Daniella, what are you thinking about this?
First of all, I just wanted to congratulate you on just 6 years of such an impressive body of work, really well researched and just such thoughtful comments. I think in terms, I always think about what's the policy angle in terms of moving forward. So I thought there were 3 areas for potential collective action moving forward to build on this really strong foundation that you've all created. I definitely think, as Charlie alluded to earlier, CMMI and CMCS are definitely an area of opportunity. Just today, they had a webinar that was focused on equity and social determinants of health. So I think the opportunity to try to inform a demonstration model at CMCS or a new model at CMMI is a real one, and it's one that we should think about as a collective community. Certainly the Surgeon General's recent public health advisory on the youth mental health crisis generated a lot of headlines, and I think folks on the Hill have been thinking a lot about mental health. There's definitely a need, of course, to respond to the acute crisis. And at the same time, I do think that this conversation presents the opportunity to focus on what can happen on the prevention and early intervention side. So I think some collective conversation there would also be helpful. And finally, in Congress, the Social Determinants of Health Caucus in the House, I think does present a bipartisan opportunity for us to try to really steer that to focus on whole child and whole family health. So would be great to see some partnership opportunities there as well. So again, just thank you for all that you've done and look forward to continuing to partner and engage.
Thank you, Daniella. Jim Perrin, what are you thinking these days?
Well, first of all, this is an amazing presentation and a remarkable amount of work that Charlie, you and Kay have led in really moving us this far. So thank you. That's tremendously beneficial. And I think you've laid out the issues very cleanly and clearly about what we need to be doing at this point. So I'm going to just start with a question and then offer some thoughts about Medicaid, which is one of the invest in value comments in your theme here. One is, we do know a lot of what works. We have a lot of evidence there. You've done a super job of bringing that evidence forward, Charlie and Kay, and amazingly good stuff. We really got it. And Rahil's work is so important as well in sort of giving us new strategies within that evidence. Why is it we haven't gone faster? Why are we not at this point bringing all that evidence to really serious scale instead of leaving the vast majority of America's kids and families still getting services from a traditional model that doesn't come close to meeting their needs? Question one. But then question two is, what can we really do with Medicaid? It's a tremendously valuable program. We all know its scope and benefits, tremendously helpful. We also know that the current structure of Medicaid in part continues to support racial injustice. And that is because Medicaid is the provider of insurance much more to kids of color than is the commercial market at this point. So what might we do with Medicaid? Let me just offer a few provocative options. One is not so provocative or new. It's time to make Medicaid rates at least comparable to Medicare rates. That's a 30% increase, 33% increase. In fact, we need to do it. It's actually not very expensive because it's just for the kids. Second, we need to federalize the Medicaid program. It shouldn't require Mississippi, and Alabama, and Massachusetts to find money in their state budgets, which are really strapped these days, in order to do their share of Medicaid. It's time to federalize Medicaid for children and youth. Third, we should make Medicaid a universal program, not just limited to poor kids, but rather say that every child at the time that she's born is enrolled in Medicaid. And if her mom and dad want to take her out of Medicaid and put her into employer-sponsored insurance, they can certainly do so. But in general, the benefits there will be worse than Medicaid. We could do some other things too, but let me just start with those three and try to be a bit provocative. Thanks again for your wonderful work.
Thank you, Jim. We were really hoping that you would mention universal Medicaid. Thanks very much for heading right in that direction. Sean, what are you thinking about this? Tell us your thoughts from health leads.
Happy to, and glad to be here. Thank you for the invitation. And although I'm employed by Health Leads, I'm here today on behalf of the Community-Based Workforce Alliance, which is a multi-organizational collaborative that came together near the onset of COVID-19. And I'm thinking, so much of healthcare for the majority of people currently amounts to a series of often disconnected point-in-time interactions, usually interventions as opposed to preventative, proactive wellness care, as others have said. And given the complexity of the issue, it is difficult to name a singular solution, but there are effective yet undervalued levers for change, as Charlie has underscored for us. And one such lever are these community-based workforces, those in communities who possess the cultural context and life experiences to be able to not only deepen those transient interactions with the healthcare system, but also advocate for the needs of their communities. And as others have shared, it is truly self-evident that early childhood care has a lifelong impact and is a cornerstone of individual as well as population health. And community-based workers can and do make a difference in bridging community and health systems through culturally informed health promotion and education. So the imperative that InCK Marks has outlined is really an imperative overdue in some ways, and also one that has never been more salient than during our current reality. And I think this crisis helps to present an opportunity for truly transformational change that is sustainable.
Thanks so much. Appreciate those comments. I have not seen Gretchen Hammer on. Is Gretchen on?
Yep, I'm here, Kay.
Oh, hi. Sorry. Go ahead, Gretchen.
No worries. Terrific. Well, thanks again for the opportunity to participate in this conversation. I guess I would endorse all of the findings and the perspectives that have been highlighted. I would, however, probably put on for consideration, put on the proverbial table, if you will, the opportunity to start in the perinatal or the prenatal period. If we think about leveraging Medicaid, one of the other places where Medicaid plays an outsized role in our healthcare system is in the financing of prenatal care and of birth. And it is really, I think, if we're going to disrupt and demand a new approach, one of the most broken parts of our healthcare system is the transition from the perinatal period to the pediatric setting. Women and families are lost. There is not good communication, and experiences of racism and other challenges in the prenatal and birthing experience can really set a family off into a difficult, establishing a strong relationship in the pediatric setting. So I would endorse everything we've talked about, but just maybe move ourselves a little upstream and think about how might we support these differences in care delivery models, investing in, as you said, payment and relationships in the prenatal period. And at some point, we've got to solve the gap between the birthing experience and the pediatric setting. That is a gap that doesn't work well for many families, even high-resourced and privately insured families. It's a real challenge there. So I think that we can take all of the great work you've done here and continue to build it in that space as well.
Thank you so much. As you know, I spend half of my time on the perinatal side and half on the child side. So it really rings true with me and others who are writing in the chat. Pradeep Bidwani, what are you thinking about out there in the clinical world of Southern California?
Well, interestingly, picking up on Gretchen's point, I think we should actually go for a -1 year initiative for the year prior to conception if we really want to do this right and come from a perspective of women's health and apply our early childhood mental health principles to that population. But what I would say is we've shown here that we need to expand the number of kids who are being treated and really expand that to kids who have mild to moderate developmental behavioral concerns. And the way to treat that is really engagement with the parents. And as we engage parents, I think it's so important not to underestimate the impact of trauma, personal, historical, and just there's so much trauma that our families have dealt with. And so I think it's unfair to ask our families to navigate our incredibly broken systems and challenging systems without help. And again, work we do here, but also Rahil's group just does great work when we think about how do we help families move through the system with support and really using attachment relationships with parents to help heal trauma. And with that, I just think it's really important for us not to underestimate the need for reflective practice for especially community health workers, but all of us who are working with families with trauma, and really understanding that secondary trauma is so devastating to our workforces. And we can see that with the COVID situation, that, you know, just how much secondary trauma and how much trauma our frontline staff has had. We just need an approach that really builds a different degree of strength. And I'll leave it to Bob Sege to talk about, to give us hope.
Great. We are next going to go, Bob Sege is on tap, but we're going to next go to Elisabeth Burak.
Hi, everyone, and I thank you so much for allowing me to be a part of these conversations the last few years of this project. And I know I've learned a lot from Charlie and Kay over many years. You know, as many of you know, with Georgetown, we think a lot about the role of Medicaid in this space. And I think, Charlie, you explained very well why Medicaid has to not only be a partner in this, but really a leader and rethinking how we do business. And especially the day after we celebrate the service of Martin Luther King, you know, I've been thinking a lot about how do we re-envision and dream differently about what kids need. And I think the urgency is clear. I mean, I think everyone is worried about kids in general coming out of COVID. And we're talking about a lot of families, especially low-income families, that were already struggling. And it's 2 years later. I mean, I look at my 11 and now 6-year-old who started this when they were 4 and 9, and the anxiety and all the things that they're experiencing. And I think we have even much more urgency. And if we don't start to think about big ideas for moving forward, then we've already lost, especially when it comes to health equity and racial equity. And Medicaid has a role to play. I think folks know it's designed for pediatrics to really focus on preventive primary care. It's intended to do that, and we have not lived up to that promise, despite the fact that it's almost as old as the program itself, and trying to figure out how to evolve and serve the needs of kids in the context of their families and communities. So I like, Mayra, you said disrupt, defer, demand. I think we need to do that and figure out where the leadership is on this. I agree it needs to start before birth, that we do have leadership on looking at maternal health and perinatal health, and how do we merge what we're doing to use that opportunity to say what needs to happen for the new mom and the newborn in that first 12 months and well beyond. And frankly, this is about financial incentives. And we know that while children are the largest group of Medicaid beneficiaries, we don't spend the most money on them. Dr. Perrin had a great vision for how we change Medicaid and make it universal. I think short of that, we can also think about, like Dr. Perrin and others have proposed in Massachusetts, you know, why don't we ask managed care plans and Medicaid to dedicate a percentage of their funding or their funding from Medicaid to pediatric primary care? How do we incentivize the team-based care that Dr. Briggs talked about with folks like models like Healthy Steps? We know what works. How do we align the finances to do that? I think there are ways to do that in federal law, and states already have the tools. So to me, this is very much about leadership, which I realize with a lot on their plates, states are taking a lot in, but this is really such an urgent need. I think that's what we need now, is really transformative leadership to get this done well. So
Thanks so much, Elisabeth. Ed Schor, thanks for joining us today.
Well, by this time, all I can do is second what everybody else has already said, but let me make a few general and specific comments. One is that the circumstances we're in really reflect systemic political decisions that have been maintaining class distinctions. So we need to take a look at the bigger picture and the biases that are built into our political determinants of health, not just what we can do on the ground level. This has other much more major implications and sources. Second, Jim's comments on Medicaid, I thought they were all terrific. One other thing one might consider is that preventive care need not be a risk-based insurance program, but we know what kids are going to need. You don't have to use insurance to pay for it. There have been some comments on prenatal care. I think obstetrics has really missed the boat in terms of addressing social determinants of health. The adverse factors that affect children, by and large, are present before they're ever born. And we need to take the opportunity to address them during that time. Another thing in terms of practice transformation, which I think we have underestimated the complexity of, is that most of the poor children in this country receive their care in academic medical centers and in federally qualified health centers. Academic medical centers don't do a very good job of primary care, so that needs transformation. Their existence tends to crowd out community primary care practices in nearby neighborhoods. And FQHCs, although their largest population are children, have never focused on improving quality of care for children. So there's another place we need to be working. And finally, metric transformation is one of the cores that Charlie has suggested. We need to be measuring and making sure that we disaggregate those measures by race and ethnicity so we can make important comparisons. But the other thing missing in the metric field is we have never held anybody accountable for the metrics that we found. And so we really need public policies that start to address the absence of accountability for these abhorrent data that we have been finding.
Thanks so much, Ed. Bob Sege.
Thank you. I want to join Ed in saying ditto to everything that was said before. I really have been taking notes and appreciate those comments. I have just one or two things I want to add. The first one is that when you look at all the programs that Charlie listed, we really do know what to do. And altogether, we reach a tiny fraction of children in the US. And part of the point that Charlie made is building this public health workforce. Almost all of the programs have a person in addition to the medical staff that provides preventive services, whether it's through Healthy Steps or Dulce or centering parenting or the medical legal partnerships. And we need to go out there and say that families come to healthcare to help them raise healthy children, but it can't be on the pediatrician alone because we're A, not qualified, and B, too expensive. And we know what to do. Secondly, when you do that, there need to be standards and understanding of what those community health workers need in training and support. That too often they're thrown into the setting and they end up becoming resource navigators rather than true partners for the families. And the programs that have worked have devoted a significant effort to training and supporting them. And the final thing is that we have to acknowledge that pediatrics needs to leave the medical model. The medical model is based on reaction. You identify a problem. I have a lump. My throat hurts. I'm having trouble breathing. And then we doctors are good at dealing with that. What we're talking about is fundamentally different. And that when we talk about this, we need to begin with the strengths and stamina that families and communities bring and collaborate with the families to help them optimize their child's development. And frankly, this is not a problem-oriented situation. And we are part of healthcare, but we can leave the medical model.
Thanks so much, Ed. And last but not least, Dina Lieser.
Well, first I have to echo everybody's comments and really just commend you and congratulate you on such a robust and important body of work during these extraordinary times of urgency and opportunity that everybody's referred to. I do want to make one quote from the executive order on advancing racial equity, but for too many, the American dream remains out of reach. Entrenched disparities in our laws and public policies and in our public and private institutions have often denied that equal opportunity to individuals and communities. As was already shared, I mean, your work is so very aligned with MCHB priorities and our mission to improve the health and well-being of America's mothers, children, and families, meaning each and every one of our families and children. And our recently strategic plan is really also clearly working to advance health services, achieve health equity, and develop systems. But I did want to say I appreciate the recognition of our siloed systems, as well as the shout out to HRSA and MCHB and ECCS, which has been really working towards this since 2003. However, the most recent iteration of the ECCS program is deeply aligned with your very focused strategic agenda. It's the ECCS Health Integration Prenatal to 3 program, and really intentionally focusing on the health system in coordination with the broader early childhood system, really trying to address that silo, thinking deeply about what health systems transformation looks like in that space, being very intentional to bridge and to be inclusive of the prenatal and perinatal space, and to bridge that connectivity that was discussed early before. And, you know, also really building in that foundational commitment to equity. I wanted to just briefly touch upon our acknowledgement that our system, some of the federal actions that need to be taken in order to really facilitate this work. And we are really excited about some work that we're doing in partnership with the ASPE, taking a look at over 30 federal programs, inclusive of MCV, of Title V, of Medicaid and CHIP, and TANF, and childcare, and so many more, and really trying to ask ourselves, how can we get to some of the root causes of the barriers to coordination? How are or aren't our programs promoting equity and really trying to optimize well-being and flourishing, taking that approach and dissecting the ways we might ask for measures and needs assessment sometimes get in the way of coordination. And this project is anticipated to yield some concrete recommendations for us to take at the federal level, and also emerge with actions that are to move forward at the state and community level. So again, just
Thank you, Dina. Thank you so much. It's great to have a federal perspective in the midst of all of this. This has been an extraordinary set of comments. I am going to do the very briefest synthesis that will not do justice to this, but I've captured a lot of key ideas, and perhaps Charlie can share those all back with you. Starting with this dyadic thinking that so many people have mentioned, there are 2.2 million babies out of our 3.8 million birth cohort in Medicaid. This isn't 40%, this isn't 50%, it's 2.2 million out of 3.8 million. And we have the opportunity to do something for the woman postpartum and the baby with continuous coverage for the first year. Charlie's slide said focus on children. Let's hear it for focus on young children, focus on birth to 3, focus on prenatal to 3, building on what works. We heard again and again, faster and better, investing in value, particularly in primary care transformation, was something that's team-based and augmented and has a relational workforce. And as you know, I call that a high-performing medical home. We've proposed some metrics for it, but clearly measuring it and getting Medicaid to pay for it. We need those incentives for states and the MCOs, and we need the leadership to come from Medicaid, federal, state, and the MCOs, as well as the providers themselves. We really need this kind of transformation. I think that having a federalized program would be a huge step. How fast we could get to a universal program is not clear. Fulfilling the promise that we know is all here, and going forward with what we very much know, Mayra told us to do, to disrupt, defer, and demand. And at what Rahil reminded us, that it should be impossible for any of us to argue to ignore the equity issues, and we must start with our babies. So real quick, Rahil and Mayra.
Thank you. Go ahead, Mayra.
Oh, no, go ahead, Rahil.
Oh, I was just going to very quickly say amen to Gretchen and Pradeep and others that we can always go earlier. We can talk about prenatal. We can talk about preconception. How do we make sure that we get folks who aren't going to have children? How do we make sure that we get fathers? I don't mean to be flippant about this, but working with infants and toddlers is prenatal and preconception work. These are the next generation's parents and caregivers. If we want to go early, let's go back to that very, very first years. And to Jim, thank you for those clear and concise suggestions for Medicaid. I will just share with you, someone once pulled me aside. They said, Rahil, do you want to know the problem with Medicaid? And I got so excited and they said, it's not Medicare. And it's just going to take us so much longer to scale effective solutions if we have to solve that payment puzzle state by state. New York wants to compete with California, and that helps, but South Carolina may want nothing to do with what New York and California propose. And that just means that it's going to take so much longer on the ground to scale these effective solutions. Mayra?
Thank you. I also want to just really appreciate everyone's comments, both those that were verbal and in the chat. And I want to build on Ed Schor's comments about health being political. And, when we think about kids, it's across the political spectrum that kids are a priority, that we invest in the kids, we invest in our future. And I think we need to start as health advocates, as child advocates, start really holding our political leaders accountable to that commitment so that it is not just a talking point, but that it is actually operationalized in our financial commitments, our investments, and the way our policy unfolds and our programmatic priorities. And I think many of us gave ideas here today about what that looks like when it's operationalized. And I think until we start really considering our children's health as a political issue, we're not going to make the progress that we want to make. So linking it to the politics of today, linking it to the movement that we are seeing to demand better for our communities, both communities of color, our rural communities, our poor families, and really ensuring that as our children are the priority, we can make that change, that difference happen when we link it to the politics of tomorrow. So really appreciate those comments and thank you for allowing me to be a part of today's discussion.
Thank you so much. I'm going to just foreshadow that Charlie and Maxine may go a minute or two over, but we are almost finished. Charlie.
Yeah, well, thank you very much. Thank you, everybody. And on the right-hand side, it says we can achieve collective impact if we engage in collective advocacy. And I really do want to thank all the presenters and all the people who participated in listening mode and chatted in. There was talk around leadership. We have a tremendous leadership here. I've learned from so many different people in this work and drawn upon them. We had 5 leading pediatricians who spoke, who developed programs and worked in some of the toughest climates going forward. And we're going to hear from the 6th to close us out. I just wanted to say very briefly that at InCK Marks, we've really taken the Margaret Mead theory of change, and that we do have the collective mass. And I think I want to make sure to go forward with all of you in carrying the charge. We are in the right place at the right time and have the right collective capacity to change this future for our kids. And we'll be getting in touch with you. We have your emails, and you have your spheres of influence. Encourage people to look at this presentation. It will be up on our website, or look at our materials, or do other things that contact your legislators and members of Congress. But really getting out the word around these 3 basic points and truths, and then what we can do to go forward. One of my mentors and dear friends is Maxine Hayes, who is a director of public health, but before then worked in Mississippi as a pediatrician. And she has co-chaired and done everything and beyond that we've asked of her as far as InCK Marks. So I just wanted to give her an opportunity of the final word in closing this session. This is my email address, and feel free to contact me at any time. I'm ready to try to organize whatever I can for you to help you get out the word.
Maxine, can you come off mute and join us?
Well, it's been such a pleasure and an honor to be involved with this work and to see all that we've learned and to articulate how it can be used. But I am also very moved by the fact that this comes at a time when we just celebrated Martin Luther King's 93rd birthday. And there is something to be said about the problems we're trying to solve right now as a nation, with so much division and so much that contributes to health that we often don't talk about. But I think as leaders, we've got to talk about the very soul of our nation. And one thing that was said in the celebration of Martin's birth yesterday that just resonated so much with me, and it is that we live in the present, but we live for the future. And if we don't really believe that in our hearts, understanding that our children are not the ones that are experiencing an even, what do I want to say? We don't have an equal starting base. It's inequitable from the very start, and we've got to care about that inequity. And we've been given an opportunity, I think, especially on the health side, that the number one issue in health, if we are trying to solve it, is really the racism. And we've got to really understand that and not be afraid to call it in our leadership roles with all the other things that we know to be true. It takes courage. I grew up with the civil rights movement, and it took courage, even when the children themselves marched. It took courage, and we've got to have the same amount of courage as leaders and reflectors of our nation's health to bring this into the picture of our narrative as it relates to health. And not to do it would be really a missed opportunity. We've got to keep this in the conscious of the nation and in front of us as providers of care. We've got to, because it is the future for a whole generation we won't get a chance to see, but they will be the beneficiaries of an even playing field for every child. This picture says everything. We want to have a level playing field for all of the women and children that start the whole thing going from history. So our work is cut out for us. We've had a lot of things we can do, and we have a lot of material that we can use, but I also want to challenge us to think beyond where we are today and how we also have to deal with the hate and the racism in our society.
Thank you, Maxine. Thank you so much to all for sharing your visions. And we so appreciate having that be our closing word. Thanks to everyone for joining us. We're adjourned.
Thank you.
Thank you, Maxine. That was great.
Well, I had to say it.
Thank you, Charlie.
I want to make sure to capture all the chat, so I'm trying to make sure I can copy that down.
I don't know why I can't get out of, oh, I should leave here.